Hey folks, my name is Amy Pearlman. I am a urologist and men's health specialist, and I have a very special person with us today. His name is Dr. Cass Igram, and he specializes in the back. He's actually an orthopedic surgeon that performs spine surgery on pretty complicated patients. Cass, say hello to the group.
Morning, everybody.
So Cass and I initially met probably a year ago when I was building my testicular pain team. And the tricky thing about testicular pain is it can be caused by a variety of different things. And some of those causes can be from the electricity that comes from the back. And so between Cass and I, we actually share some mutual patients. So I met with Cass in his office, and he did something very interesting. He had a very nice espresso machine in his office and offered me a cup of espresso, and I subsequently rushed to the store to buy my own espresso machine because I thought that was a nice touch. So Cass and I have become friends because of the espresso. Cass is going to talk to us about low back pain, which is a very common thing that occurs in really anyone, not necessarily people we consider to be patients. So Cass, with that, let's see it.
Thank you, everybody. So I'm Cass Igram. Thank you, Amy. I'm coming to you from my office in the basement of the U of I hospital. I'm with the Department of Orthopedics. Everybody's kind of on lockdown right now, but we can still get information out. So I'm just going to go through my talk on low back pain, something that's pretty common to my practice. And will we have time for questions afterward, or are we just going right through the talk?
I'll ask you some questions at the end. How about that, Cass?
Okay, let's go to the next slide. All right, so low back pain, here in our orthopedic department, we see a lot of patients with spine problems. Back pain is a very common reason why people are referred to our clinic. And as you can see, lifetime prevalence, 80%. That means there's a lot of people that will experience back pain in their lifetime. I think I've seen statistics that show it's the second or third most common reason for people to visit their primary care physician. Most of the people we see that have back pain, it's typically so-called myofascial, pulled muscles, colloquially. Most people get better. 2 to 3 months time, it'll resolve on its own. May or may not be associated with an injury. I mean, it's not uncommon. Patient will say, "Doc, I was just getting up in the morning, felt something pull on my back, or I was bending over to put on my shoes." So not necessarily associated with trauma. Next slide. So 3 broad categories. Mechanical low back pain, meaning that it's associated with movement. Non-mechanical low back pain, probably pain that's just arises for no particular reason. And then visceral pain. And this one can be a little troubling at times. Patients who have, for instance, something within the abdominal organs, for instance, an aortic aneurysm, people who have sometimes with a hot gallbladder can present with back pain, sometimes with cancer, like a tumor, for instance, that might be eroding into the spine.
And Cass, not to interrupt you, but sometimes what we see in the urology office is kidney stone pain, and that's flank pain.
Absolutely. And so it's interesting. So I've had kidney stones. I know exactly what that pain feels like. And so, somebody who's never had a stone before, I swear to God, I've had people who've had stones that have been worked up for, back pain and so-called pinched nerve and whatnot, and totally missed it. And for somebody who himself has had a kidney stone, I know what that pain feels like. And so it's really easy for me to spot it, flank pain, hurts when you go to the bathroom, burning, all those things. It's pretty unforgettable pain. So yeah, it's easy for me to diagnose it having been a victim of a kidney stone myself. So next slide. No, that's a good point. Thank you. Thank you, Amy. Interesting fact. So here we go. Back pain is a very common reason for disability. Sadly, second most common reason, or most common reason for disability for people under 45. Second, until recently, second most common cause for missing work, irrespective of the virus. Second most common cause for a physician visit, probably second or third. Third most common cause for a surgical procedure, meaning there are a lot of people out there that, for one particular reason or another, for a back problem, are having elective operations. As you can see, pretty high cost of treatment. And then, of course, if you add in the cost of treatment and then the lost productivity, you're talking into a very large dollar amount. I mean, I think I put there 50 billion in for treatment. I wrote this lecture probably about a year or two ago. I'm sure that's gone up. And then lost productivity. Each year, approximately 2% of the workforce is compensated for disability related to spine problems. Next slide. So initial evaluation, somebody comes into the office, they're complaining primarily of back pain, may or may not radiate, meaning going into their legs, sciatic nerve. Although I had a patient last week who I asked him where his pain was, and he said it was his psychotic nerve as opposed to his sciatic nerve. And I was a little puzzled, and he said, well, it's my psychotic nerve, doc. It's making me crazy. Like, okay, that was clever. I had to give him credit for that. Multifactorial, meaning that, patients, it can be associated with different things. Might be worse in the morning, might be worse with activity, or sitting for long periods of time. Walking maybe helps it. Is there a history of an injury? Or are you in a car accident maybe a week or two ago and been having back pain ever since? And then, of course, constitutional symptoms, weight loss, unexplained, night sweats, unrelenting night pain. These are all concerns for something a little more sinister. Next slide. Contributing factors. So without a doubt, unhealthy lifestyle does not help your back. Smoking, heavy labor, job dissatisfaction, depression, they go hand in hand. It's pretty hard to have a sunny disposition if you have chronic pain. People who tend to have ongoing back pain, they usually do not have a real sunny disposition. Static positions, meaning staying in one position for a long period of time. Prolonged sitting, prolonged standing. These tend to be aggravating factors as well.
Hey, Cass, going back to contributing factors of smoking,
Yes.
would you offer someone surgery if they're a current smoker, or do they need to stop?
We make them quit. And then for good measure, we do urine nicotine tests to verify.
Yeah, and what is the reason for that?
Smoking, the main factor, there are many factors, but one big one is smoking really decreases the amount of oxygen that your blood carries, and oxygen is very critical for proper bone and wound healing. So if somebody's a smoker, smoking really impairs that process. So biologically, it's not a good situation, especially if we're going to do like a fusion on somebody, a spine fusion, for proper healing of our fusion. There's very conclusive literature that shows that smokers, it's harder for them to form a fusion as opposed to non-smokers.
Yeah, so it's not just you being a stickler, it's that you're trying to set your patients up for success if they're going to undergo an operation.
Well, absolutely. We are performing elective operations. And so what our really proper care of that patient is to try and maximize the chances for success. And if we have known contributing factors that will impair our success rate to have this patient do well, one of which being smoking, another one is diabetics who, if their A1C is totally out of control, those are factors that we can control. And so that's a good point, Amy. We are not trying to be punitive. We are trying to do the best we can to take care of somebody. And if that means you need to quit smoking to have an operation to help them, then so be it. That's what we do.
Yeah, and then there is, I'm not sure if you're aware of this, but through the state of Iowa, Quitline Iowa offers a free resource to patients. People don't even need a referral. They can just Google Quitline Iowa and reach out, and they offer free health coaching for getting off of tobacco, and they also help people get free nicotine replacement therapy.
That's good to know. I guess I was unaware. I know here at the U, if we have people who live in close proximity, we do have resources available. Sadly, Amy, I'm sure you have the same experience. We have patients that sometimes come from 2-3 hours away. So it's those resources aren't always available for every person we see, but we try and do our best, or have the family doctors help us out. If somebody wants it bad enough, if they are having pain, there's no reason to continue smoking. It's bad for you. So that's usually the way I put it. We're trying to help you, and this is one step in that process.
Great.
There's a
All right.
question from the audience too. Along with the smoking treatment, do you also have them seek treatment or some sort of aid for depression or anything like that prior to surgery?
We do have some capability through our spine center. We have a clinical psychologist. We do try, and if we have somebody who's got clinical depression, yes, we do try and mitigate that as best as we can. And if we have somebody who's on, let's say, not only that, but on narcotics on a chronic basis, our anesthesia pain clinic will also help. Lee Kroll is a valuable resource. She's our clinical pharmacologist who helps us in those circumstances. I mean, it's a lot of times you have to really come at these patients from different angles, handling the smoking, getting their diabetes under control, getting their depression under control, getting their use of narcotics under control. I mean, there's a lot of moving parts to really try and maximize, if we are going to finally bring someone into the operating room, to really maximize our chances for success. And you heard me say earlier, people who have chronic pain, it's hard to have a sunny outlook on life. So you really need to try and at least improve their depression, if you are able, ahead of time, because that'll help you post-operative.
Yeah, and to piggyback off of what Cass was saying, is within the anesthesiology department, there's Lee Kroll, who's the pharmacologist or the pharmacist who meets with patients, and she does that for free. That is not she doesn't bill for that, and she'll sit down with patients and go through their chronic medications and describe the pain pathway. And then there are actually 2 psychologists within the Department of Anesthesia who are pain psychologists who will sit down with patients for 2 hours and then schedule follow-up visits and really go through that pain pathway and teach coping mechanisms. And that's a very easy referral to place through a university.
All it takes is a click and Epic, and Lee is fabulous. So, all right, next slide. So red flags, I touched on this a little bit ago. Say we have somebody, so actually here's an example. So a couple of days ago, I took care of an elderly gentleman. He's a farmer, lives up in north central Iowa. He's about 80. He'd been having back pain since December, all right? Fell out of his combine, had been bothering him for 3 months, getting steadily worse. He had been seeking treatment, chiropractor, a little therapy. It turned out that he had a tumor in one of his vertebrae that eventually brought him to our hospital. Was he having any constitutional symptoms? I mean, he's 81. He really can't remember. But, this guy had been having pain that was waking him up at night. He wasn't necessarily having any weight loss. He's got no prior history of cancer, but you really need to be concerned. If somebody's having pain for that long of a period of time, finally he had an MRI scan, and it showed this tumor that was in one of the vertebrae, meaning that I'm usually pretty liberal about ordering MRIs if I have something that just doesn't seem right. A patient comes in and says, "Doc, I just lost 30 pounds. I wasn't even trying." Or I've been running low-grade fevers. Or I have a history of prostate cancer and I've been having this back pain and I'm getting really worried. Or, of course, trauma usually is pretty self-explanatory. But, I think you need to really be on the lookout for unusual circumstances. You don't want to miss something like this gentleman that I just took care of who had been having back pain since December. I mean, it's easy in retrospect, but that's a situation that you really want to try and head that off before it gets too far. Next slide. So physical exam. It's been very strange recently. We've been doing some telemedicine visits. Part of what we really do, and me as an orthopedic surgeon, being able to lay hands on patient and examine them, check their strengths, check if they have numbness, check their reflexes, how, when they walk, is there anything odd about that? That's pretty hard to do over the TV screen. And I have to say, I'm really not a big fan, but that's kind of our situation right now. However, when we do have patients in the office, we want to try and at least do a fairly comprehensive but focused exam on their spine. We want to know where their pain is. What makes it worse? Is it better when you sit or stand? Do they limp when they walk? Do Do they have weakness? Do they have numbness? How about their reflexes? Do they not have very good reflexes? Next slide. And again, red flags. Patient comes in, maybe they have pretty significant weakness in their legs. We'll see people in the emergency room with really significant neurologic deficits from time to time. Impairment of bowel and bladder function, which is very concerning. That usually means that they probably have either compression on the cord or something called Caudy-Quinas syndrome, which is compression on the spinal nerves, which typically constitutes a surgical emergency. Next slide. So this is just a little schematic that I probably took off Google. You can see on the left side, we have the vertebrae, or the tan parts. The discs are the blue parts, kind of looks like the double stuff of an Oreo cookie. That's a schematic of what healthy discs are supposed to look like. And then on the right side, what a degenerated disc looks like. And sadly, as people get older, it's just like having an old car. You drive a car for 50,000 miles, it's going to have some door dings and scratches, and the tires are going to wear it out. People, as they get older, the parts wear out. Sadly, there's really no way to reverse that.
Hey, Cass, look,
go ahead.
I was going to say, looking at this picture, and you're talking about the Oreo, and I think, well, that's not a healthy food. That's probably going to make people overweight. You know, talk to me about obesity and what this does for disc degeneration.
Oh, without a doubt. Well, we talked about smoking, which accelerates that process. So, and again, smoking cuts down on the amount of oxygen in your blood. The discs do not have native blood supply. So they depend on oxygen to make its way into the disc space. And anything that you do to cut down the amount of oxygen in your blood is bad for your discs. Obesity is another big problem. We see people, you know, so the so-called body mass index, which measures your body surface area. It's a calculation based on height and weight. Over 30 by FDA standards or by government standards, it's considered obese. So a BMI over 30 is not a healthy body habitus. BMIs over 40, at least in my world, is morbidly obese. And so a lot of this extra weight really bears down on the spine. And that's not a situation that really helps to keep your spine healthy. Now, that's not to say we haven't operated on people with BMIs that are that high if our hand is forced in an emergency situation, but it makes it very challenging to do spine surgery on somebody with a BMI over 40. It's not something that I would, if we are going to do elective surgery on somebody, we really try very hard to get their BMI under 40 for many reasons, not the least of which it's a challenging undertaking and the complications are higher.
Great, thank you.
Yeah, no problem. Next slide. So imaging, you know, when somebody first comes in with back pain, you know, we will typically get x-rays. You know, to start out with, are they an absolute necessity? If we have somebody who, let's say they were at home, maybe spent a lot of time gardening and their back was pretty sore the next day. That said, x-rays are usually pretty easy to get. Now, as far as advanced imaging, a lot of people are familiar with MRI. That's typically my advanced imaging procedure of choice. CAT scans are good for looking at bony anatomy. And we do get CAT scans fairly frequently here at our hospital, especially in a trauma situation if we're looking for fracture. But usually our main imaging modality of choice is the MRI. I put in lumbar discography for historical purposes. That's not a test that we are really doing routinely. As far as advanced imaging here at our hospital, it would be by far and away MRI followed by CT. Next slide. So on an x-ray, patient comes in having back pain. We'll take an x-ray. You can see where the arrow is pointing to the disc between the fifth lumbar vertebrae and the sacrum. X-ray would read this out as a very significantly degenerated L5-S1 disc. And you can see how the disc is collapsed down till it's almost bone rubbing on bone. Some people will have a disc that looks like that and not have very much pain. Some people will have a lot of pain. It's really quite variable on what their response can be to what we see in an X-ray. Next slide. And similar situation. Here we have an MRI scan. You can see the bottom two discs look a lot darker than the discs up above. This is a pretty typical MRI in an adult. Radiology, again, would read this out as age-related degenerative changes of the discs between the fourth and fifth lumbar vertebrae and the fifth lumbar vertebrae in the sacrum. Next slide. And then, of course, a CT scan. Here on the CT scan, you can see the bony anatomy very well. You can see between the fourth and fifth vertebrae, very crummy looking disc space. You got little chicken beaks there with bone spurs that indicative of a degenerative process. Next slide. So treatment. How do we treat back pain? There are a lot of treatment options out there. We as orthopedic surgeons, especially here in Iowa, are typically not the first choice for back pain. Iowa's got a lot of chiropractors that see a lot of back pain. I would assume fairly well known that the Palmer College of Chiropractic Medicine in the Quad Cities was, I think, the first one in the country. So Iowa, I think, at least my impression has been that we do have a pretty large share of chiropractors practicing here in the state. And for a lot of patients, that's the first line of treatment, is seeing the chiropractor. Now, granted, some people will come see their family physician or come to see us. Most people, as I said, their history is fairly benign. They will get better. We do not necessarily put them on bed rest, but maybe restrict activity for a time until they start to improve. We use anti-inflammatories, Advil, Aleve. There's a lot of generic ones out there. I try very hard to avoid narcotic medication. In fact, I usually reserve that for patients that we've operated on. I typically will not put people on narcotics for back pain. We use therapy a lot, modalities, icing, heat, ultrasound, again, limiting activity, lifestyle modification. Here you go. Listen, long term, you need to quit smoking and see if you can get your weight down. That will help you. The good news is many people, if we simply let it run its course, they will get better. Next slide.
Hey, Cass, real quick question here.
Sure.
Who should someone in the community see as a first-line person if he or she experiences back pain?
You know, I think that the family physician is an appropriate choice. Here, obviously, as specialists, it's a little harder for people to get in right away to our clinics. Now, that said, you know, we do try and get people in as quickly as possible. I will get referrals from chiropractors around the area. You know, I have to admit there are some of them out there that are fairly savvy and can recognize that, hey, we got a problem on our hands. You need to really see a specialist. You know, so for the most part, I think that most patients, unless there's really something odd about their condition, usually seeing the family physician, there's a lot of patients that will go straight away to physical therapy. In Iowa, that is an option. And then, of course, through chiropractors. But always bearing in mind, if you have a patient and it's been, say, like, you know, 3-4 weeks, and they're not really getting any better, they probably do need to see a specialist to make further inquiry. Usually, if I have a patient who's been having back pain for, let's say, like a month or so, and they're not making any improvement, I'm usually pretty liberal about ordering MRI scans in that circumstance. In those circumstances, see, I hate to miss something that's out of the ordinary.
Okay.
So next slide. Oh, here we go. So I put this slide in here because I get this question a lot. Doc, you know, what else can I do? And so I did show in this slide that there is no scientific support for, and consequently, typically there is very little in the way of insurance reimbursement for acupuncture. Now, chiropractors do get paid, I think, through a lot of insurance plans. There's some treatments that don't, but the scientific literature doesn't support to a degree of high satisfaction, any of these treatments, acupuncture, chiropractic manipulation, dry needling, prolotherapy, traction, inversion tables. I have a lot of patients who love their inversion tables. I usually don't talk them out of using them, but you know, if you want to spend money on it, feel free, even though, yeah, there's really not a lot of literature to support it. Laser treatment, I don't know if anybody's really paid attention. There were a lot of ads for several years on television for the laser spine centers. They've all gone bankrupt. So those have gone away. So that said, none of the above treatments have proven superior to doing nothing and letting most back pain, which is benign, run its course. So next slide. So exercise. We use therapy a lot. And the goal with therapy is to learn appropriate exercise, working on core, low impact aerobic. Obviously, when you're familiar or been familiarized with these exercises through a good therapist, you should be able to do them at home. And so we typically try and get patients to move past PT where they can do low impact exercise, bike, stationary bike, elliptical, swimming, working on core. If you can achieve that end, then a lot of those patients will get better by themselves. Next slide. Injections. So epidural injections. We have a very good pain center here at the university, and epidurals are definitely part of our practice. That said, if somebody has just straight up back pain with no radiating pain, meaning no like sciatic pain or nerve pain, epidurals have very limited benefit. They are helpful for patients that have pinched nerves, but if you just have straight up back pain, I typically do not send patients for injection. Next slide. So operations, when do we operate on somebody with a back problem? If we have somebody who's got a pinched nerve, then that's something that can come to an operation. Obviously, if we have somebody with back pain that's secondary to a tumor or something very sinister of that nature, a fracture or a tumor or maybe a spinal infection, then that's something that can come to an operation. But for the vast majority of patients that have back pain with maybe degeneration of the spine, no pinched nerves, then very limited benefit for an operation in that circumstance. Now, there is some literature out there to suggest that, well, if you have properly selected patients, that doing a spine fusion can help their back pain, or another option, so-called disc arthroplasty, a disc replacement that you can use to replace a degenerated disc. Here at the University of Iowa, there is no surgeon who is doing lumbar disc replacements between the orthopedic department and the neurosurgery department. It's really not anything that's in favor at this time. I still get asked questions about it, but people aren't doing them here in Iowa. Next slide. So that's what a spine fusion would look like. You can see kind of the very white object is a plate. This is actually going through somebody's belly, and you put a bone graft in between the vertebrae. So the first step is to remove the disc space in its entirety, and then put a piece of bone in there, and then fuse the two vertebrae together. Next slide. And this is what a disc replacement looks like. Again, you're going under the premise that you have a crappy disc. It's very arthritic. You're removing it and putting in a disc replacement, analogous to like a hip or a knee replacement. If only a disc replacement enjoyed the same degree of success as a hip or knee replacement, but sadly it does not. Next slide. So chronic low back pain. This is a tough patient population to deal with. You know, chronic low back pain, if you've been having pain for, it's a little arbitrarily defined, but if it's been 12 months with ongoing pain, that's considered chronic low back pain. Sadly, there are patients out there that just for one reason or another, they have back pain off and on during their adult life. As I said earlier, depression is a real problem in that patient population. Substance abuse. Listen, before the virus, everybody was well aware that we had an opioid epidemic here in the States. You know, the pain is a fifth vital sign, and just the very almost epidemic use of narcotic medications for pain. It was just very out of control. And I think, we are taking steps to really curb some of that, but that's a very slippery slope. And that's why people can, get dependent on heavy duty narcotics. If there's secondary gain involved, litigation, maybe somebody who's in a car accident, a work injury, these are all complicating factors that can really make it difficult to dig out of a hole and get somebody back to being able to function and get their pain under control, and so they can move on with their life. Next slide. We can skip this one. Let's go to the next slide. So treatment. How do we help these patients? Obviously, we want to intervene early. We want to have them do therapy. We want to have them do rehab. And if we have a multidisciplinary pain center, like we mentioned earlier, our clinical pharmacologists in our anesthesia pain clinic. Yes, antidepressants can help. Yes, we'd like to use anti-inflammatories. No, we want to avoid opioids. We talked about injections having limited benefit in an operation under very slim circumstances. An operation can help back pain, but that is definitely not the first choice. Next slide. So in back school, now this is something that's been around for a long time. And what exactly is back school? Back school is basically, kind of how it's described. It's meeting at a spine center, learning, it's patient education. Listen, we understand that you have pain. Being able to work with the amount of pain that you have and trying improving your function, and knowing that, yes, if you do have pain, are you harming yourself by trying to increase your level of function, return to gainful employment? I always think of it, the analogy like an athlete. There's athletes who are hurt and athletes who are injured. All right. You might be hurt. Let's say maybe a football player tweaks his knee and his knee hurts. Does that mean he shouldn't play in the game the next week? No, he probably can return to play, as opposed to somebody who tears his ACL. That athlete's clearly injured. He's not going to return to play. For back problems, it's very similar. Yes, the back hurts. Are you going to do yourself bodily harm by increasing your level of function and trying to get back to work? The answer is probably not. And so a lot of time is spent really trying to coach these patients that, listen, we can help you work through this and hopefully get you back to some level of function so you can get on with your life. Next slide. So summary, most back pain, thank God, is benign. There are a minority of patients that do have bad things going on with their spine that can cause their pain. Tumor, trauma, and infection come to mind, and we see a lot of that stuff around here. Treatment is typically straightforward. Slight activity modifications. We don't want to do bed rest. We don't want to do narcotics. We want to maintain some level of activity, have them exercise, do therapy, and we want to try and do everything we can to prevent that patient from progressing to a chronic back pain patient. Next slide. So I guess that's it for my slides. If there's any questions, I guess we can entertain them now.
Awesome. Thanks, Cass. That was awesome. So we have Kristen here. Kristen, wave. Say hello. Now, Kristen, she works for the University of Iowa, but she's also a patient of yours, and she's been through some of this stuff with her own back issues. Kristen, what was going on before you met Cass, and how has your life and your symptoms changed after your surgery with him?
So I've known Cass for quite a while, actually, probably like 15 years. Yeah, when he was practicing here in Des Moines. But my problems with my back started probably 20 years ago when I was pregnant with my first child when I was in college, because I had sciatica pretty bad. And I was young and dumb and didn't really go to my family medicine physician about it. I went to a chiropractor who I did not research. And I think I was like 6 or 7 months along. And from there on out, I had problems with it. And so it would get better and then it would get worse throughout the years. And I am 100% guilty of needing the quick fix. So I
You're
would,
not the only one who's ever said
I
that.
know. And that's when I worked for accelerated physical therapy too. So I worked with a ton of physical therapists, but I would get injections because they typically, worked like that day, if not the next day. And when it would get aggravated again, it was typically because I was running, or it would usually be a workout related injury or how it would aggravate again. And my physical therapists were constantly like, Kristen, you need to start therapy. You need to work on your core and all that good stuff. But I think I went to one of my physical therapists here in Des Moines, who's like a spinal PT, great guy. And I went and saw him like January of last year because it had aggravated again. And he saw me for like 2 sessions and he's like, Kristen, you need to see a spine surgeon. And I was shocked. I was like, what? I don't
Well, now, Kristen, you should probably stop for a second too. So now, a couple of things. You don't really have a lot of the risk factors that we talked about earlier. You're not a smoker. Your BMI is pretty good. And, you don't do heavy labor, right? And you're not diabetic. So, but we do see a lot of patients out there that fit that story, that they live a fairly healthy lifestyle, but their back just bothers them. But you also, the other thing you probably need to talk about is that at what point did it go from, my back flares up on me to you started having pain going down your leg, so-called sciatic pain?
Yeah. I mean, it would always end up going to sciatic pain, but my injections would usually fix it. So before I started seeing the physical therapist, Dion, here in Des Moines, I tried an injection and I know the anesthesiologist pretty well. And I texted him the next day and I'm like, it's not working. I need another one. And he actually did another one, I think 2 days later, and it didn't work. And that's when I saw Dan, the PT, and he's just like, you've got to see a spine surgeon. And so that's when I text Cass and I saw him like probably 2 days later and got an MRI and had surgery probably within a week. So it was honestly the best thing I ever did. I was very worried about the recovery time, even though Cass was like, you'll be fine, you'll be fine. And I know I was like walking a couple miles probably a week after surgery.
Now, Kristen, and so I'm sorry to interrupt you again, but an important point. Besides back pain, you had a lot of pain going in your leg, and as I remember, you had some weakness in your leg too.
Yeah.
And of course, I don't recall prior MRIs except for the one that I got, but you had a very large ruptured disc that was pinching nerves in your back.
Yeah. Yeah. And I mean, I couldn't bend over anything. And it would be weird. Every time it would flare up, it would be down one leg, maybe the right leg or maybe the left leg. It just always varied. And again, I never thought I would have had a ruptured disc or was even a surgical candidate until Dan said I needed to see, Dr. Igram. So
that's really key, because if you had not had any pain going in your legs, sciatic pain, that typically would not be somebody we would consider doing surgery on. But the fact that you had a lot of pain in your leg is really what tipped it toward an operation.
Yeah. Yeah. And I mean, it got to the point, again, because my injections weren't taking, but I couldn't sleep at night. I was in so much pain. So again, having surgery was the best thing I ever did. So I owe it to you, Cass.
That's why
Kristen,
we're
talk
here.
to us about your symptoms afterwards. Like, did you continue with physical therapy afterwards? What's the ongoing management after surgery?
Yeah, I did physical therapy, which was, Dr. Igram's post-op protocol. So it went really well. I probably didn't do as much physical therapy as
earmuffs, Cass, earmuffs.
I know, only because like my PTs are also my friends because I used to work with them. And so I'm probably spoiled in that manner, but I progressed very well, very fast. And I think it was because I was in shape prior. That really helped. Now I do have a problem with core strengthening, which they always tell me that. So I really worked on doing my at-home exercises more religiously and being a better compliant patient. I think part of my problem historically was I was a non-compliant patient. I mean, I'd go to physical therapy like once or twice and then I'd just stop and, just go back when it flared up. And so I really worked on being more compliant.
Now, Kristen, I'm not naive. Patients don't do everything I tell them to do.
Well, we'll wrap it up. Cass, is there anything you want to add? Kristen, anything you want to add before we shut this down?
No, as you, Amy, as you're well aware, this is a crazy time here at our place. And sadly, we're really not able to take care of our patients in the manner we're used to at this point in time. That will pass. It's a little bit of a moving target, but, I think that in general, we're here to help. I mean, we get patients from all over the state, and we get patients from our backyard. I mean, it's, does everybody need to see a specialist? Probably not. But on the other hand, if there's patients who want to come see us, we try and do our best to accommodate. So, and Amy, I'm sure you say the same thing. I mean, it's, it just, to get back to our practice the way we knew it is really important right now. I mean, these telemedicine visits just are not really that satisfying for me.
See, I love the telemedicine visits because I do a lot of men's health. And so a lot of that stuff actually, it works out for my specific patient population.
Really? I don't know. I just miss the interaction with people. It's, doing it on the TV screen, it's okay, but it's nice to see people in the clinic.
It is, yeah. Awesome. Well, thank you all for your time this morning. I learned a lot today.
The pleasure was mine. Anytime. See you, everybody.